So we can definitely see the reason why here, but let's shift gears a little bit and think about some of the challenges. Chris, diverse communities are often described as hard to reach. Do you agree with that in your community? And how do you ensure as a patient organisation that a really diverse community is included and it's not just the voice of the few, but it represents the cohort?
Struggle with this one a little bit. We're in this strange situation where we have 800, give or take, known patients in the whole world. So we have no choice but to, from the outset, engage with everyone and anyone as best as we can. It's been kind of ingrained from 35 years now, I think it is, since the IFOPA, the USA FOP patient organization was founded, and they were founded with PenPal system, reaching out to everyone around the world who also had that condition, which is kind of where we come from to it from a starting point. However, there are definitely challenges that I can kind of see. I'm hoping others will contribute to this a little bit more, but barriers such as language and access to technology, barriers within communities, resistance to actually getting involved, but also barriers to access to healthcare itself. There's one kind of particular barrier that comes to mind, and it came to mind because we rely heavily as an organization on social media, on the internet, on being connected. But there's a lot of patient communities from different diverse backgrounds that don't have access to these tools and technology. And it's come to light quite regularly of late, because as patient searches are taking place in underdeveloped countries or less connected worlds, there's challenges there in how you reach people. So you don't necessarily go social media anymore. You may need to go back to WhatsApp at best, old school text at worst, technology-wise, or even taking a further step back and actually distributing information to clinics or surgeries or via other channels where these patient populations might stumble across the information that's really important to them. And that's definitely one of those challenges that's hard to define, hard to tackle. One of the other challenges is, of course, and it's probably going to become a regular theme and will be for many, is how do we, as small patient organizations, tackle diversity when we're already struggling to address the issues of the many? You know, if we do an awareness campaign, we're doing it socially, and then we go, oh, right, whole other budget, whole other set of resources if we need to go down the text route or the media route or printed materials in clinics, all of that kind of stuff. So it is definitely a challenge and tricky. I'm sure there's other challenges that I've not touched on. Hopefully someone else will, but that's kind of my perspective, experience of it so far.
The social media one in particular, I think, is a really important point to make. I mean, there is an assumption now, isn't it, that everybody engages on social media. If we put it out on Facebook, everyone's going to see it. But of course, that is not the reality. And you're right, there are certain cohorts in particular who, while they may be on it, aren't using it to engage in things related to their personal health story and things like that. So, but then of course, there's a cost burden, isn't there, on a charity if you've got to find these other outlets. So I think that's something that needs to be joint conversations between the likes of industry and the charities, that actually, if there needs to be another strategy, how is that going to be funded? How are we going to reach those people so that we don't have just the same old people participating in the studies, but everybody's got an opportunity to be involved, regardless of whether they want their health footprint or engagement on Facebook. So I think that's a really important thing. Jan, I don't know, and we're going to come to you as well in terms of the challenges, so maybe you can address that as well. But, you know, how do you as an organization make sure that you get that diversity and depth of engagement across the board?
Yeah, absolutely. So obviously, I mean, there are very strict rules and guidelines, you know, in the way industry can work with patient and patient organizations, and these are obviously necessary to protect the patients. But obviously, they also put boundaries to what we are really allowed to do. And the way we usually kind of start, I think, is really kind of working with patient organization, because, you know, kind of they are also a natural partner to try to identify and understand that patient perspective. And, for the diversity and across the different projects that we've done, we always try to make sure that we are working with patient organizations from different geographies, countries, with different background. But as Chris mentioned, I think there are always, kind of certain limits. And I think this is where kind of recognizing the limits and then again, kind of, I think working together to try to overcome these limits, is what is really needed. I think there will always be, I think groups of population that might not be that just do not want to engage. And so you can find alternatives, but there will always be, I think, methodological limitations to what you can reach. But I think it's definitely an area where I think we are getting better. There is the recognition of the issue, but more can be done, I think, to find solutions together. And I'm also glad, that Chris shared his perspective on that.
Thank you. And Nadine, obviously you can look at this from the perspective of a patient engaging in research, but also a researcher, working with patients. So what do you see as the barriers to that kind of diverse engagement?
Yeah, I think so. A few points had been mentioned before already by Chris and Judith. And so I guess like one barrier definitely can be the language, because, if it's in an international setting, then English would be the language and not everybody can talk English. But I think also like a barrier in terms of language can be that we don't talk the same language when it comes to like technical terms, because, like each field has their own technical terms. Like researchers, we have our own language. Then of course, patients, they have their own language. And, like bringing them all together, let's say kind of in layman terms, if you want, can be challenging. And, first to find this common ground, I think can be a challenge too. And quite honestly, it can also be like just time, because, as a patient, I mean, we still have our work life, we have our personal life, then, we have the condition. So we might have a lot of doctor visits or something. And then like if you're involved in different maybe associations, committees or projects, it can be very time consuming. And like in my case, I can tell you, I love doing it, but I'm involved in so many things. Sometimes I'm like, I don't know when to do all of this. And I just love doing it. So that's why I'm like, yeah, sure, I can do this, I can do this, I can do this. But at the same time, I'm trying to pursue my PhD. And sometimes I'm like, oh yeah, wait a minute, that's actually my job right now. So, we have a day job, then maybe we're parents. So also, we have to take care of our children. So, and mostly I feel that the people who are getting engaged are those people who maybe actually don't have the time because they already have so much on their plate. And, like it's a small community. So I think it can be also challenging to motivate people to become engaged. And I think also like, since I'm on the board of the German FOP Association, I think I can also talk just a little bit about perspective, like getting other people engaged. We struggle a lot with that. And I think Chris can agree on this. It's really, really hard to motivate other people in the community. So yeah, I don't really have an answer how we could make it more attractive to other patients or other caregivers to get engaged. I thought I'm doing a good job in trying to get others engaged, but I don't know, like, where that, but I think that's a whole nother issue. And,
I'd like to delve into two things you said there. One was around the technical terms and that kind of language in terms of the nuance of language, I guess. And I'm wondering whether, do you feel that something might be valuable at the start of these projects is almost coming up with like a lexicon, a kind of agreed set of terms and principles that bridge the gap between what the patients might be saying and what you might say in technical terms as a researcher? Could that be a good sort of starting point and also a good way of bringing people together on a project with a commonality?
Yes, definitely. I think something like a glossary maybe, or something that could be really helpful, if like people start using abbreviations. For me, that's the worst. Like if people start throwing in abbreviations, I'm like, okay, I have no idea what we're talking about here actually right now. And sometimes the same 3 letters, they can be abbreviation for something completely different. And that can also lead to misunderstandings. So yes, I guess that would be very helpful. And also some projects, because that ties back to what you just said, they can be actually really complex and they can require some pre-knowledge. So also there it would be really helpful if we get like a briefing document or information material or something just to get prepared. And of course that needs some time, but I think we're willing to learn, whatever it takes to be educated. And especially if it comes to policy, I have to really say for myself, like, it's really difficult for me because like I've never been into politics, so I really don't understand, I would say, anything about it. And then, again, if they start throwing in tech terms, I'm like, I get so lost really, really quickly. So yeah, it takes some time to, I guess,
like
educate yourself.
Preparatory work that really should be done at the start of the projects then. And the other thing I wanted to come to was you talked about the burden of time and that kind of motivation. And I know something that we hear a lot is that patients get a bit of fatigue for participating in these things because they feel like it is research for research's sake, because they may never hear the outcomes, or something's published, but has anyone thought to send them the paper so that they can see the outcome of it? So do you feel from a patient perspective that more should be done? And I guess this is for you as well, Chris, to make sure that there's updates on what is happening with that research, and so that they feel that for that investment of time they can at least see something happening, or even if something hasn't happened, that is reported, that it's not gone anywhere or whatever. How do you think that could be better managed perhaps?
Yeah, I think that's actually a really good point. And honestly, I have to say, even though I am a researcher myself, I have actually never thought about that too much. And yes, I guess it would be important to communicate back to the patients or patient organizations that, even maybe if it's a negative finding, it's still a finding, or, just giving an update, like, we've been working on this and that. And I think even, if you do publish it in a journal, again, it's like in a very technical language, and sometimes even so technical that some scientists, maybe they won't understand because they're just like too many like difficult words in there. So I guess we definitely need to actually break it down and not educate, but inform the patients, because as Chris was saying, like, a lot of patient organizations, they fund research. So they should also get something back from it. And not only, like, if they find a result which like benefits or impact their life, but really just communicating. So really, I think, again, communication, a good communication is really the key to a successful collaboration.
So maybe we need to be looking at kind of this lexicon and briefing documents at the start, but then throughout, sort of the translation of the published papers and the outcomes into lay summaries that can go back to, back to Chris and back to yourself to disseminate to the patient. So it motivates people as to being part of this process rather than just something that you're extracted information from, and it feels a bit more collaborative.
And actually the lay summaries is also one of the things we are kind of committed to, and the other thing is also making sure that published research is accessible, that there is not a paywall when you try to access the articles, etc., because again, in the spirit of giving back and making sure that this is accessible, I think that's also a commitment that we have as a company.
I think that's really
important. It is really important, because if you continue to get nothing back, you stop giving.
Yeah, I was just thinking, I was a participant in some research during COVID, a study looking at healthcare professionals and just asking things about, had you had COVID and things like that. And I got regular email newsletters from the study saying, this is just the update. This is how many patients or how many people we've got recruited. We've written this paper, and actually just listening to this conversation, it's made me reflect that was actually really good practice.
It really highlights it. It's one of my bugbears is if I send an email, even if you can't answer my email, send me something back saying, I can't answer your email. Otherwise, it's just, oh.
Yeah, it is. You feel like it's just gone out into a silo, and then, where's it gone? It's gone into the void and we hear nothing. So I think that's a really important lesson, isn't it, in terms of managing that. And Judith, in terms of the NHS and healthcare settings, I know that the NHS are quite creative in terms of how they can work with diverse patient groups with, translation, for example, services that you use and things like that. What are the other ways perhaps that you are making sure that you're engaging with a diverse community for research?
Yeah, so I was thinking about this, and it is a bit of a challenge for us because we're slightly limited in that the patients come to us via like their GP or another doctor, and we don't go out looking for patients, or we which makes it a bit difficult, if that makes sense. So yeah, I think one thing we do is we if somebody contacts us and sort of says, oh, my GP won't refer me, that's quite common actually. My GP won't refer, they don't know that you'll take me, and that sort of thing. We will reach out to GPs and go, yes, we, or actually if we're not suitable, then we say no, we're not. But yeah, and translation services, so that's changed as well. So we use telephone interpreters in our clinics. They do come, that does become a bit of an issue around research, like Nadine was saying. Yes, we get I've worked in trials and studies where we've had patient information, translated into different languages for people to be able to read and everything. But there is a little bit of a limitation still because of taking consent. And if I'm speaking English and somebody else's, I need to be absolutely clear that they've consented to the process. So yeah, I think it is difficult for us particularly in a specialist sort of hospital setting. I think in general practice, the NHS is probably a lot better at this. But also thinking back to what Chris said before, a lot of the tools we've started to use are all, internet based, and I think that does make a big difference. Those of us who use it all the time, it feels like normality. But even even within our patient populations, I mean, particularly not necessarily in rare diseases. I also look after some fairly common diseases, but things that affect older people, and they may not access things in the same way that my younger patients do. So that, that diversity is important as well.
I think it's easy to forget the digital poverty that actually, like you say, when you use it, it's an assumption that everyone has access to that. But of course, that is not the reality.
Certainly not. I mean, even in the UK, not the reality. Certainly lots of people without smartphones know they don't have a computer at home or an iPad, and things that many of us will take for granted as being just a normal part of life. And I was really interested about what Nadine was saying about sort of fatigue and being always asked. And I will admit, I am guilty that if you ask me, say you choose disease X and say, oh, we need a patient for that, it's the same people who come to mind, because they're the people who've engaged before or who've said to me in a clinic, oh, I don't mind being involved and things. But I think sometimes, and also empowering people to say, you do have skills, you have knowledge, and I think personally, I'll say I need to be a bit better at that. But
and maybe it goes back to a little bit like Chris said at the very start, that kind of like, well, I'm just a dad, or I'm just a patient. You hear the word research and policy and you think, oh, I don't know anything about that. But of course, it's just your lived experience. It's what you do know. And Nadine said it at the start, you're the expert. So actually it's demystifying what that really means, that research and policy. And it's just about sharing that storytelling, like you said, Judith. So I think it's just education, isn't it? That it isn't that daunting experience that perhaps we think. I'm mindful of time and I want to get through everything. So before we jump on to the next section, looking to the future, I just want to finish this particular bit with you, Chris, and ask, you did mention a little bit in terms of that, finding different ways of sharing resources and things, but are there asks from you as a patient support group? Like, what would make it easier for you to engage with your community and to bring them along in this research and policy journey? Are the things that would make it easier and tools that you could use?
It's like I'm like a broken record sometimes. It really is levels of support. Yeah. And quite often for smaller patient organizations, that just comes down to funding. A large proportion of us are volunteers. We're doing this alongside our day jobs. I'm currently skipping out on a board meeting to be here today, and skipped out on something else last night to do another webinar. We're also, as Nadine has said, we are either parents, patients, or family members. We may have other siblings to look after. We certainly have lots of hospital appointments. So boiling it down to needing more money seems a bit limited, but actually funding patient organizations properly, a base level of funding from somewhere means that they can achieve a lot more with what they've got. It may mean that we as an organization have a dedicated person who can help with all the day stuff, so you can do all the additional patient engagement activity and all the rest of it. Because don't forget, patient engagement activity is often on top of everything else that we're doing for the community. So we get involved in helping people with EHC plans. We get involved with connecting them to doctors. We nag GPs and all the rest of it quite regularly on behalf of our patients or families who aren't as resilient, involved in a lot of stuff that isn't patient engagement. So then you throw that into the mix and it's just another thing. So actually resourcing. And I know that other countries
listening that will resonate with that, I'm sure.
It's quite interesting because we do, I in particular, Nadine as well, being international, we work with a lot of other national organizations. And in other countries, some do have this basic level of funding. You know, they have funding that allows them to run community meetings. They have funding because they've got members. And it doesn't have to be massive amounts of funding, but enough to make an organization sustainable and effective across all the things that it's trying to achieve. And that's funding that's just provided. That's not, oh, I'm going to go and have to, you know, run a Tough Mudder. I'm going to have to go and do a marathon to raise this funding to support ourselves, because that again is just another thing on the organization's shoulders.
Sustainable, real seed funding to help resource.
Yeah, not unrestricted, of course. You know, you have to be a real organization and you have your real community and all the rest of it, but something that's just that base level that makes it a little bit easier to keep going. And this is even more relevant, I think, for we're really lucky as a rare disease that we have a lot going on, from pharmaceutical through research. We have reasonable funding levels across the world, but there's loads of others that don't even have that. So if they're also trying to just get off the ground, again, that basic level of, okay, I don't have to do 2 jobs. I can focus on getting this patient organization going and getting engaged with the patients. All the rest of it. That would really, really make a big difference.
Yeah,
the other thing, of course, is kind of, and a lot of, we have umbrella organizations which provide a great level of support, but again, often that's on us to find. So I know of Genetic Alliance UK, Beacon for Rare Diseases, all of these organizations, but there's no central place that goes, right, I really need to know about the NICE process now. Go here, they can signpost me to all the relevant places. I really need to know how to deal with politicians. Go here, I really need some advice on an awareness campaign. You have to go and find all that stuff out for yourself still. So those kind of things. So it's money and actual guidance support, I guess.
That's fantastic. That is really insightful. Thank you for that, Chris.